So in this session, we will see how we should get prepared to anesthetize a pediatric patient. Anesthetizing a pediatric patient is always a challenge even for an experienced anesthetist. A pediatric patient is quite different from an adult in many respects. They are different from an anatomical point of view, from a biochemical metabolic point of view, from a physiological point of view when you consider different physiological systems of the body, cardiovascular, respiratory, metabolic, thermoregulation and many other systems. And from a pharmacological response point of view also, a pediatric patient is very different from an adult. In addition to that, pediatric anesthesia embraces a wide range of patients, starting from premature neonate to an ordinary neonate to infants through to juvenile patients and adolescent patients. And at the same time, pediatric patients can have many different medical or surgical problems that can complicate your anesthetic. So that could range from, again, mild upper respiratory tract infection or a common cold to a serious congenital heart disease. Now let's look at the different stages of getting ready for pediatric anesthesia. First is venous cannulation. Venous cannulation is a challenge most of the times. And as you all know, kids are more prone to bradycardia with induction of anesthesia and during maintenance of general anesthesia, which may even end up in a cardiac asystole. Therefore, you have to stabilize IV access, preferably before general anesthesia or at least within the first few minutes after starting general anesthesia. So what are the things you need to get ready for a difficult cannulation as expected in a child? So you need the tourniquet to get a vein more prominent. You need plasters cut and prepared early. Small gauge intravenous cannulae like a yellow cannula which is 24 gauge or a purple cannula which is a 26 gauge cannula. Of course, you need an assistant to keep the hand or the leg still and to stabilize the arms and to paste the plasters, etc. Then you also need to have the IV drip prepared beforehand. So the preferred intravenous solution for pediatric anesthesia is Ringer's lactate or Hartmann's solution, and you always need a burette set to titrate the intravenous fluid intake in a pediatric patient. Next is to look at the upper airway. So as I mentioned earlier, upper airway of a pediatric patient is quite different from that of an adult. And there are many differences in the upper airway that have a special significance on anesthetizing, laryngoscopy and intubation of a child. Pediatric patients have a relatively short neck, a small mouth and a relatively large tongue, which makes it difficult to maneuver the airway equipment like laryngoscopes, endotracheal tubes and Magill's forceps inside the patient's mouth. The larynx of a pediatric patient is placed quite anteriorly and relatively higher. That again would make direct laryngoscopy and intubation quite difficult. At the same time, a pediatric patient is at a greater risk for hypoxia due to several reasons. They have a higher metabolic rate and a higher demand for oxygen, and at the same time they have reduced oxygen reserves, and closing volume can occur within the tidal breath. Therefore, minor decrease in functional residual capacity of lungs can increase the pulmonary shunt and can lead to lung collapse. Therefore, applying continuous positive airway pressure or CPAP is essential to improve oxygenation and to reduce work of breathing. Because of these reasons, before embarking on induction of general anesthesia on a pediatric patient, you have to be ready with all essential airway equipment, with the idea at the back of your mind that there is always a possibility of having a difficult airway, difficult laryngoscopy, or difficult intubation. Since pediatric anesthesia embraces a range of patients from premature neonates to adolescents, you have to be ready with different sizes and different types of airway equipment to be used on patient's age and growth. So you have to have face masks, oropharyngeal airways, laryngoscopes, laryngeal mask airways or supraglottic devices, and endotracheal tubes of different sizes and different shapes. You need pediatric face masks of different sizes and shapes to suit different sizes and shapes of faces. You can use either circular masks or triangular masks. Transparent face masks are better because you can see both misting and secretions through those. Sometimes children can be distracted by transparent masks with a colored rim. You need the Mapleson Pediatric Breathing Circuit, which is specially designed for children for anesthetizing pediatric patients. It has an open-ended bag with minimal dead space, and the whole system has a low resistance for breathing. Oropharyngeal airways sizes ranging from 000, which is the smallest one, then 00, 0, 1, 2 and 3, 3 for a bigger child. Then laryngoscopes blades again starting from 000, 00 and 0. So 000 would be the one suitable for a premature neonate. 1 and 2, 2 for a relatively grown child. And better to have both curved blades and straight blades ready at hand. And it's always better to have pediatric McCoy laryngoscope blades ready at hand. Then you need endotracheal tubes of different sizes and different shapes and different types depending on the age and growth of the child and also the type of surgery. So for a premature neonate, the size of the endotracheal tube would be size 2.5 or 3, whereas for an ordinary neonate it would be 3.5. For grown children, the type of the endotracheal tube, the size of the endotracheal tube can be predicted by a formula which says age in years divided by 4 plus 4. Then better to have a range of endotracheal tubes to select to suit for the different types of surgeries. For an example, you will need a south ray endotracheal tube for surgeries like a cleft lip or cleft palate surgery or nasal surgery. And reinforced endotracheal tubes would be better for oral and maxillofacial surgeries. And ordinary plain endotracheal tubes are needed for all other surgeries like a laparotomy or a surgery in limbs. There's no need of cuff inflation in endotracheal tubes. Laryngeal mask airways or supraglottic devices are also essential and should be ready at hand. Sizes range from size 1, 1.5 to reinforced laryngeal mask airway, laryngeal mask airway with a special pose for gastric suctioning, intubating laryngeal mask airway, eye gel, and a laryngeal mask airway for a bigger child. To be used in case of a difficult airway or difficult laryngoscopy, it's always better to have video laryngoscopes and pediatric intubation fibroscopes or pediatric intubation video endoscopes ready on your difficult airway trolley. Sucker or suction apparatus or wall suction ready should have been checked before starting anesthesia. Sucker handles and suction catheters should be ready depending on the type of surgery that you are going to anesthetize the patient for. And it's always useful to have a head ring, a shoulder roll, and equipment to reduce heat loss. Now, to reduce heat loss in a child, you have to have a special consideration in your mind and you have to have those special equipment ready at hand in the operating theatre. So you will need a warming blanket, a warming mattress, and fluid warmers. Better to keep the patient with the cap and leggings on to prevent heat loss. You need to arrange monitoring for general anesthesia before starting anesthetizing a child. Minimal requirements for general anesthesia are pulse oximetry, ECG, non-invasive blood pressure, captometry, airway pressure, fraction of inspired oxygen or FiO2, and temperature. At the induction of anesthesia or before starting induction, at least pulse oximetry should be set up, and soon after the child settles down, ECG and non-invasive blood pressure has to be set up. At the induction of anesthesia or before starting induction of anesthesia, airway probe for capnometer should be fixed and attached to the pediatric breathing circuit, and with onset of anesthesia, pulse oximetry has to be set up. Soon, non-invasive blood pressure and ECG has to be set up. You have to be very careful with the drugs used on children. You have to decide on which drugs to be used on this particular patient and draw only the dose calculated for the patient's body weight into a syringe. Label the drug properly and keep it ready at hand to be used when necessary. Have intravenous atropine drawn to a syringe, and the dose to be used in case of a bradycardia has to be predetermined. And you should always know where exactly adrenaline lies on your drug table so that you can draw it or take it in case of a cardiac arrest. So that's a summary of how we should get ready before anesthetizing a child. So in summary, before starting induction of anesthesia in a child, we have to get ready with equipment, utensils, tools, instruments and consumables necessary for monitoring, intravenous access, airway management and emergency airway equipment, patient warming and drugs necessary for maintenance of anesthesia. Thank you.